Namaste everybody. The today's talk is on approach to painful shoulder joint. Shoulder pain is a common and disabling complaint which accounts for about 14.7 people per 1000 patient. It is also third leading cause of OPD visit and the lifetime prevalence of shoulder pain is up to about 70%. So in summary, shoulder pain is very common in our population. Unfortunately, 78% of all the shoulder pain that comes to our OPD are diagnosed as frozen shoulder. However, only 20% are said to have frozen shoulder, 80% had other pathologies, and most common cause of shoulder pain presenting to OPD was rotator cuff pathology. Let us talk about the frozen shoulder a bit, which is the most commonly diagnosed case in our OPD. So frozen shoulder is divided into two types. So these are primary, which is also known as idiopathic, and these are secondaries. Secondary frozen shoulder are frozen shoulder that has developed out of some known disease. So the diagnosis of frozen shoulder or the diagnosis of primary idiopathic frozen shoulder is by exclusion. So if we exclude other pathologies that can cause frozen shoulder, then only we can label a frozen shoulder as a primary or as an idiopathic frozen shoulder. The secondary frozen shoulder are basically of three types. We'll go to that one by one. It is a systemic, so that means a frozen shoulder that develops with the systemic diseases like diabetes mellitus, hypothyroidism, hyperthyroidism, and hypoadrenalism. The frozen shoulder may be caused by some extrinsic problem like cardiopulmonary disease, CVA, cervical discs. There are fracture around the shoulder which can also lead to the extrinsic cause of frozen shoulder and the Parkinson's disease. The most important is the intrinsic cause of secondary frozen shoulder, and the intrinsic causes are rotator cuff tendinitis, rotator cuff tear, biceps tendinitis, calcific tendinitis, AC joint arthritis, and many more. So if you see the incidence of primary and the secondary frozen shoulder, the primary or the idiopathic frozen shoulder occurs only in about 20% of the cases, whereas the secondary frozen shoulder accounts for about 80% of the cases. So to summarize the frozen shoulder, if we diagnose a case of frozen shoulder, there is 80% chance that we'll miss some secondary causes of the frozen shoulder. So the frozen shoulder or the idiopathic frozen shoulder is diagnosis of exclusion. Pain is chief complaint and it is very misleading. The intensity of pain, the character of pain, the distribution of pain are overlapping in different pathologies around the shoulder. You can see here in acromioclavicular joint arthritis, the pain is located at the tip of the shoulder, whereas the pain is distributed all along the arm in case of rotator cuff disorder, periarthritis, and glenohumeral joint arthritis. On top of that, it's very important to understand that the shoulder pain may be radiating pain from the neck, from the elbow, and from the internal organs like lungs, heart, diaphragm, gallbladder, and spleen. So whenever we are examining or whenever we see a patient with shoulder pain, identification of a possibility of radiation pain is very, very essential and very, very important. So pain shoulder is pain for the surgeon because the pain per se gives a very less clue for the diagnosis of the shoulder diseases. That is why a systematic approach to the diagnosis of shoulder pain is very, very important. The history is very important to make a diagnosis, and in history, it is important to identify either it is an acute onset or it is an insidious onset. Either the pain is associated with trauma or it is associated with repetitive injury, which patient may have just neglected as a cause of shoulder pain. After taking a detailed history, a meticulous examination should start from AC joint, followed by rotator cuff, shoulder joint proper, and the scapulo-thoracic joint. The sequence of examination of the shoulder joint may vary according to the preference of the surgeon. After clinical examination, a focused investigation is very, very important because these investigations are neither sensitive nor specific for a particular disease. So most of the patient, they will require X-ray, some will require CT scan and MRI, and many of these patients will be benefited by ultrasonography. Unfortunately, this ultrasonography is not very popular and we don't have expert to do the musculoskeletal ultrasonography and impingement test, which is actually the injection test, and the injection, the lidocaine is given at the pain site to identify what is causing the pain in the particular patient. Only after this cycle, then you come to a final diagnosis and we plan our treatment of the patient. It is very important to understand that there are various pain generators around the shoulder. It may be AC joint, very neglected scapulo-thoracic joint can also give rise to pain in the shoulder. The shoulder joint proper can also give rise to pain. Rotator cuff muscle, any of these cuff muscle can give rise to pain at the shoulder joint. And even if the biceps tendon, which are not considered as a rotator cuff muscle, but they lie very near to the rotator cuff and may be a source of the pain in a particular patient. So the examination of the shoulder should start from the examination of the neck. We have to palpate the spinous process and the paraspinal muscle and then gently do the movement of the neck. That will give us an idea about the patient's status of the neck. Again, it is very important to examine the elbow, and the shoulder examination should not start again without examining the elbow. It's very simple, just to do the range of motion, active and passive range of motion, flexion, extension, pronation, supination, and then palpate the bony landmark, the lateral epicondyle, olecranon tip, medial epicondyle, and the radial head. So this quickly finishes the examination, which is called as a regional examination, that is the examination of neck and the elbow joint. Once we have done this neck and elbow joint examination, then we proceed to the examination of the shoulder joint proper, and the examination of the shoulder joint should start from the look. So you look at the pectoralis major from front, look at the level of the shoulder and any other asymmetry of the clavicle and the sternoclavicular joint. Then you look from the lateral side, the deltoid muscle, and go back to the posterior part. Look at the supraspinatus, the infraspinatus muscle. Look at the medial border or the vertebral border of the scapula. Also mention the distance between the midline and look at the apex of the scapula. Once we have looked, then we proceed to feel, and the feeling should start from the sternoclavicular joint. You gradually slide your finger laterally across and along the clavicle, and then we'll reach to the acromioclavicular joint. And the tenderness at the acromioclavicular joint is very, very important. Then you slide your finger to the anterior, lateral, and the posterior angle of the acromion, and then continues the posterior angle of the acromion along with the spine of the scapula. And this spine of the scapula will lead to the medial border of the scapula, and slide your finger and try to feel any tenderness at the apex of the scapula. Then again you come back in front and 2 centimeters below the AC joint there is a coracoid process. It is very important to palpate the coracoid process. Also it is of utmost importance to palpate the biceps tendon, and finally you palpate the greater tubercle, and this finishes the feel process, which is very important for the examination of the shoulder. Then we start from the move, and in move we have to start with the active movement. In this case the patient has active range of motion up to 90 degree only, and then further the passive movement is possible in this patient. So in this case, or in case of shoulder pain, both examination of the active as well as passive range of motion is very important. Why it is important is because it will distinguish either it is a frozen shoulder or it is other painful condition of the shoulder. If it is a frozen shoulder, both active and the passive range of motions are limited, whereas if it is a painful shoulder, active may be limited but passive range of motion will be possible, like in this particular patient. Then you start from the measurement. So we know that there are Calaves test and the biceps girth, which is very commonly measured, but it is very important to measure from the posterior side of the chest and the posterior part of the scapula. So 7 points has to be marked in the posterior part of the chest. Is the C1 is marked, the superomedial border of both the scapula is marked, the lateral end of the acromion is marked, and then finally both the inferior pole of the scapula is marked. Then you draw a vertical line, you drop a vertical line from the C7 and then draw a perpendicular line from the superior angle of the scapula to the previously drawn vertical line. And the distance between these two lines into the previously drawn vertical line will indicate the level of the scapula. In this case, the level of the left scapula is little lower than the level of the right scapula. Then you can continue this line to the lateral end of the acromion, which will tell us that either there is an inclination of the scapula or not. This inclination can also be drawn or can also be measured by dropping a line between the medial edge of the scapula and the inferior angle of the scapula. So here we have drawn a line that joins the medial angle of the scapula and the inferior angle of the scapula, and from the medial angle of the scapula you drop a vertical line which will indicate, and this angle will indicate the tilting of the scapula, which should be ideally identical in both the sides. After the measurement, we proceed to the special test, and before proceeding to a special test, we must understand that the pain generators of the shoulder may be AC joint, scapulo-thoracic joint, shoulder joint, or it may be a rotator cuff, and finally it may be a long heft of the biceps, or it may be from the anchor of the biceps, which is also known as the slap lesion. So the examination of all these structures are very important. So to do a AC joint examination, this is known as a cross-body adduction test. The palm of the affected side is placed into the apex of the shoulder of the opposite side, and then you ask the patient to maintain this position, and he will resist when you push down the elbow, and the patient has to complain pain at the acromioclavicular joint. If he complains of pain somewhere else, it is not significant. But if the patient specifically complains of pain at the AC joint, it indicates AC joint pathology. Scapulo-thoracic examination is very much neglected in case of shoulder joint examination. You can see here the shrugging of the scapula shows that the left scapula shrugging is very less. Then you retract and protect the scapula. You see the movement of the scapula on the left side, which is a diseased side, is lesser than the normal side. Then the forward flexion and the lateral abduction, also very important to see the rhythmic movement of the scapula. So when all these movements are done, both the scapula has to move in a rhythm and in the same manner. So here Just like to demonstrate a scapular dyskinesia, certain kind of dyskinesia which is demonstrated by the movement of the shoulder. As we see, the patient when he adducts his shoulder, you can see that in the posterior, in the infraspinatus lesion, there is a bulge, which is a feature of scapular dyskinesia. So it is very important to examine from posterior side while moving the shoulder in various range of motions. Wall push-up test is very very important to not only to diagnose the winging of the scapula but also to diagnose the scapular dyskinesia. So you ask the patient to do few push-ups, 3 to 5 push-ups, and then you examine and see the scapular location and the movement of the scapula. And this wall push-up test is also very very essential and important to elicit the winging of the scapula. Here I am trying to demonstrate the obvious winging of the scapula in case of wall push-up test. So once 2-3 push-up of the wall is done, then you can again examine the scapula and it becomes very very obvious the winging of the scapula. Next is the rotator cuff examination. We know that rotator cuff muscle is made up of supraspinatus, infraspinatus, teres minor posteriorly, and subscapularis anteriorly. Examination of each muscle is very very important, and we should not forget the biceps tendon, which is in very close proximity of the rotator cuff. So your rotator cuff examination will not be complete until unless the examination of the biceps tendon is done. So to start with the supraspinatus, to check the power of the supraspinatus, it is the initiation of abductors of the shoulder. So you resist the abduction of the shoulder and you feel the power of the supraspinatus on both the side, the affected and the non-affected side. So to test the supraspinatus, we do an empty can test in which the arm is flexed along the scapular line and it is pronated in form of emptying the can and then resisted the movement. So the patient resists, and this is done in the full supination, which is known as the full can test, and this is done in the both the side to identify either there is a pain or there is a weakness of the muscle, supraspinatus muscle. In case of supraspinatus tendinitis, there will be pain in the empty can test and the pain will be less in case of full can test. In case of complete tear of the supraspinatus muscle, the muscle strength will be significantly less. Infraspinatus is external rotator in adduction, so you test one by one and try to external rotate. Patient tries to external rotate and you resist, and in doing this way you can feel the contraction of the infraspinatus muscle and you can also feel the power of the infraspinatus muscle. A test which is done for infraspinatus integrity is known as the external rotation lag sign. So in adduction, you completely external rotate the shoulder and leave and ask the patient to maintain that external rotation. If the infraspinatus muscle is intact, he'll be able to maintain that externally rotated position of the shoulder. Whereas whenever there is an infraspinatus muscle tear, the patient will not be able to maintain the external rotation. Here we are trying to external rotate, and then when we leave, the shoulder goes into the internal rotation. So this is known as external rotation lag sign positive, which indicates that infraspinatus muscle has been torn. A horn blower sign is done to test the integrity of the teres minor. So the arm is flexed in the plane of the scapula and the patient tries to externally rotate in this position and you resist the external rotation. In doing that, you can test the power of the muscle, which is usually tested for teres minor muscle. And this can be compared in both the side for power and the weakness. Test for subscapularis muscle is very simple. This is known as the lift-off test. So take the patient's dorsum of the hand to his back and try to lift it off from the back and leave the hand in that position. If the subscapularis muscle is intact, the patient will be able to maintain that position. Here I am trying to demonstrate, and this is the normal side. He's able to maintain that position, and this is the pathological side. You can see that when we lift it off from the back and we just leave it, it goes back and hits the back of the patient. So in this case, the lift off test is positive. The drawback of the lift-off test is it requires a good range of internal rotation. If the internal rotation is limited, the subscapularis muscle can be tested by the belly press test. You ask the patient to press the belly when the elbow and the wrist are at the same plane and are at the same level. And the patient will be able to press the belly by his wrist. Whereas if there is a subscapularis muscle tear, the patient will not be able to maintain the plane of wrist and the elbow, and he tries to adduct to simulate the belly press sign, and this is known as the positive belly press test. Impingement test, the popular test for impingement test is Hawking's test, in which you flex the shoulder to 90 degree, flex the elbow to 90 degree, and then do an internal rotation and external rotation. So the patient will have pain in internal rotation and will have less pain in external rotation, and this is known as the Hawkins test positive, which is very, very significant for impingement syndrome of the shoulder. So impingement syndrome are the group of condition which is considered to be included are the subacromial bursitis, rotator cuff tendinosis, AC joint arthritis, and the hooked acromion. So all these conditions can give rise to the impingement test or the Hawkins test positive. To differentiate between either it is a rotator cuff tear or it is an impingement syndrome, we have to do an impingement test. So impingement test is nothing but injection of 5 to 8 ml of lidocaine into the subacromial space. In both the cases, the pain reduces. If the power of the muscles are normal, probably this is an impingement syndrome and the patient was not able to do the test because of the pain. If after impingement test the pain reduces but the power still remains less, probably this is a partial tear of the rotator cuff. So impingement test is very, very essential to distinguish between either it is a rotator cuff tear or it is an impingement syndrome. Examination of long head of the biceps is very, very essential. There are two important tests which is known as the Yergason's test. So flex the elbow in adducted shoulder at 90 degree. Elbow is flexed to 90 degree. Then ask the patient to do a resisted supination of his pronated forearm. So here the patient's forearm is pronated and then I am holding his hand to resist his supination. So holding the hand to resist supination, patient tries to supinate and the patient will feel pain at the bicipital groove. So this is known as the Yergason's test. Another test which is done for the long head of the biceps is known as the Spitz test. So the arm is adducted and supinated and he does a forward flexion which will be resisted by the examiner and the patient will feel pain at the bicipital groove, which is known as the Spitz test. The biceps is attached to the superior glenoid tubercle and there may be some tear of that attachment which is known as the slap lesion, and for slap lesion O'Brien's test is done. It is very popular to do an O'Brien's test. So O'Brien's test may be confused sometime with the empty can and the full can test. The difference between empty and full can test and the O'Brien test is it is done in little bit of adduction. Again in this case it is done in pronation and then the same thing is done in supination like in full can test. So the difference between the empty and the full can test and the O'Brien test is empty and full can test is done in the shoulder flexion at the plane of the scapula, whereas in this case O'Brien's test it is done in little bit of adduction. So there are various types of slap lesion. We'll not go into detail to that, and we quickly switch to the shoulder instability test. There are various tests mentioned, but the apprehension test is very, very important. So you gradually do an external rotation and the patient apprehends the external rotation, which is known as the apprehension test. The patient resists the external rotation. So this can be done in the sitting position, it can be done in the lying position. I prefer to do this in the lying position because this apprehension test can be supplemented by the relocation test. So you do an apprehension test, in that location patient will not allow you to further external rotate. Now you put your other hand into the proximal shaft of the humerus and try to reduce it, try to push it backwards by reducing the subluxed humeral head, and the patient will allow you to do more external rotation, which is known as the Job's relocation test. A sulcus sign sometimes is very important to identify the instability. Just elbow is flexed, you put your hand into the elbow and push it downwards, and then you see how much is the gap between the acromion and the humeral head. There are various grading system also has been mentioned for the sulcus sign, but I will not go into detail of that one. So once we have examined in detail our patient, then we switch to the investigation. Almost all of our patients that will require X-ray, and it is suggested that all patient of shoulder pain has to be submitted for ultrasonographic examination. Unfortunately, this is not very commonly practiced in our context. After the X-ray and the ultrasonography, nearly 40% will require a CT and MRI, and those who have some positive finding in the CT and MRI and plan for surgery will require an impingement test, and this impingement test will clinch or will identify the location of the pain, and once it is done, then we can plan for the detailed treatment and even plan for the surgery of that particular patient. Here are some graphs to show that the X-ray, this is a study which is very interesting of 203 cases of shoulder pain, and in 64% of their cases they found that the X-rays were within normal limit. And then AC joint pathology and the glenohumeral joint pathology was the most commonest pathology that could be seen in the plain X-ray. Ultrasound was done for all these 203 patients, and they mentioned that the ultrasound is the very sensitive and the specific examination. It has identified in 42% the supraspinatus pathology and subacromial bursa in 31%, and the subacromial bursal pathology in 31%. So they recommend that the ultrasonography is very important. Out of these 203, 91 had positive, only 93 patient, which is about less than 50% had positive MRI. And in MRI, there are overlapping pathology. There are pathology of not only one structure, or there are pathology of multiple structure has been noticed. So unfortunately, these all literature have mentioned that the ultrasonography of the shoulder is very important, but in our context, this is a big question how we can utilize ultrasonography for diagnosis of disease to our patient. As of now, we have to rely on the clinical examination because MRI is very much misleading, and our radiologists are not expert to read the MRI, and we are also not very much expert reading an MRI. This study mentions that the combination of clinical examination and ultrasound scan is very important for making a diagnosis of shoulder pain. Other radiological tests are of limited value. So they emphasize on clinical examination and in ultrasound. Just a brief about the impingement test. Impingement test is a diagnostic test in which local anesthetic is injected into the suspected pain generating point of a patient with impingement sign. Relief of pain following the injection during provocative maneuvers is helpful in confirming the source of the symptom. So impingement test is very important to locate from where or from which source the pain is generated. So impingement test in this case, just to demonstrate that this is an OPD procedure of subacromial infiltration after the cleaning of this region is done in this case. Once 7 ml of local anesthetic, in this case along with the along with the dipomedrol has been given into the subacromial space. Then after some time you re-examine and test all those positive findings. That will give us an idea either the pain is generating from subacromial space or it is generating from other places. So to conclude, shoulder pain is common symptom. Many joints and muscle pathologies may give rise to pain in shoulder joint. Various tests are available, but their sensitivity and specificity are still debated. A standard examination protocol is key for the diagnosis. Thank you very much for your patient hearing.